Dear friends, in this video, I am going to talk about acute pancreatitis, pancreatic pressure, and intra-abdominal hypertension. Now, it is a common admission in the patients with acute pancreatitis who subsequently go on to develop a high intra-abdominal pressure leading to intra-abdominal hypertension, and that creates a pancreatic pressure. So let us start with the case of 70-year-old male who presents with abdominal pain and distension for a week, with history of loss of appetite for a month with no other positive history. The patient has decreasing urine output for 3 days. The blood pressure is 104/46, heart rate is 108, respiratory rate is 36, saturation is 92% on room air. The patient is initially admitted in the ward, but subsequently deteriorates with a fall in blood pressure. Patient is administered IV fluids to the tune of 1.5 liters. And after that, in order to maintain the mean arterial pressure of above 65 millimeter of mercury, the patient requires noradrenaline at the rate of 0.1 mics per kg per minute. So this is the point where the patient gets shifted to the ICU. And the laboratory parameters show a very, very highly raised lipase, 1500, and a moderately raised TLC. The other investigations are apparently normal. A bedside point of care ultrasound shows peritoneal effusion with multiple septations, and that raises suspicion because the intestinal loops appear dilated with very thin wall on the sides. And on CT abdomen, there is acute necrotic collections in the pancreas, along with free fluid in the peritoneal cavity, along with dilated loops. But there are no clear signs of ischemia or perforation. Now, this is when the diagnosis of acute necrotizing pancreatitis is arrived upon. Whenever we talk about acute necrotizing pancreatitis, we differentiate it from interstitial edematous pancreatitis on the basis of the collections. In interstitial edematous pancreatitis, where essentially there is peripancreatic fluid collection, which is of acute onset, and there is a homogeneous fluid adjacent to the pancreas without a recognizable wall initially. So the timeline for this is 4 weeks. After 4 weeks, the acute pancreatic fluid collection, peripancreatic fluid collection progresses to a condition of pancreatic pseudocyst, where there is an encapsulated, well-defined extrapancreatic fluid collection with minimal solids. On contrary, in acute necrotizing pancreatitis, there is collection both within and outside the pancreas. So there are both intra and extrapancreatic necrotic collection, and this progresses after 4 weeks into walled off necrosis, or WON1, with a formation of a well-defined wall. Now, the outcome in these two conditions varies. While it is not so bad in interstitial edematous pancreatitis, neglected acute pancreatitis can have a much worse outcome. As per the revised Atlanta classification, this severity can be very simply classified into mild, moderate, and severe based on the presence of organ failure, the persistence of the organ failure beyond 48 hours, and the presence or absence of local or systemic complications. Accordingly, if there is transient organ failure, which is less than 48 hours, it is moderate. And when it is more than 48 hours, it is severe acute pancreatitis. Without organ failure and without local or systemic complications, the diagnosis is usually mild. This is important because without organ failure and with organ failure, the mortality steeps up or jumps up. With pancreatitis, which is mild with no organ failure, the mortality can be less than 1%. But the same pancreatitis, if it becomes necrotizing pancreatitis with organ failure, and its mortality increases to almost close to 5%. And if it becomes infected, after infected necrosis, the mortality can become between 15 to 25%. So there can be almost a 25 times jump in mortality from beginning from mild pancreatitis with no organ failure to severe pancreatitis with infected necrosis. Now, this is the reason why it is extremely important to classify these patients and to identify at what stage of this continuum they are in at the time of intervention, at the time of ICU admission. And in this case, and in this regard, intra-abdominal pressure should be measured in all severe acute pancreatitis cases that worsen despite adequate treatment in the ICU, because these are the patients whom a lot of whom might actually have a poor outcome. So what is intra-abdominal hypertension? This is a process in which a progressive increase in intra-abdominal pressure occurs, which cannot be compensated by abdominal cavity compliance, and this results in multiple physiological consequences, including renal dysfunction, splanchnic hypoperfusion, decrease in the cardiac output, and a reduction in respiratory system compliance. So conventionally, it is divided into 4 grades, and grade 1 is intra-abdominal pressure of 12 to 15 millimeter of mercury. Grade 2 is 16 to 20. Grade 3 is 21 to 25. And grade 4 is more than 25. However, whenever there is sustained intra-abdominal pressure of more than 20 millimeter of mercury in presence of a new organ dysfunction, we label it as abdominal compartment syndrome. So it is very important to measure this intra-abdominal pressure early to establish the baseline pressure, particularly if the patient is progressing from mild to moderate to severe pancreatitis over a period of time. There are some risk factors for abdominal compartment syndrome, both primary and secondary. And as we can see in this list, that most of them are predictable. That is, any patient who is admitted with pancreatitis, it can be quickly surveyed to find out which of these conditions are present in that patient. Whenever these patients are present, factors are present, and the patient is likely to be at a high risk of severe acute pancreatitis progressing to organ failure, and organ failure is persisting beyond 48 hours. If the patient arrives late, then it can be expected that the patient is likely to have a poor outcome, and all interventions should be done early to give the best possible chance to the patient to survive. Now the question becomes then, why the acute pancreatitis patients are so prone to develop intra-abdominal hypertension? Well, there are 3 mechanisms for this. One, the factors that decrease abdominal wall compliance. These are the factors often present in acute pancreatitis, and they include pain, abdominal wall edema, and obesity, and they finally lead to intra-abdominal hypertension. There are factors that increase abdominal contents. So gastroparesis increases the abdominal contents, ileus, ascites, retroperitoneal hemorrhage and leading to edema, and acute fluid collections. So all of these factors increases the abdominal contents, for which the patient develops intra-abdominal hypertension. And the third mechanism is the factors which increase capillary leak or fluid overload. And this includes massive fluid overload and also multi-organ dysfunction. Now, it is good if we can understand the close relationship between fluid administration and intra-abdominal pressure. It has been seen that liberal fluid administration or very high administration of fluid can affect to an extent that it causes a steep rise in the intra-abdominal pressure. However, there is one misconception that if a patient doesn't have pulmonary edema, it is safe to give him additional fluids. But truly speaking, it is not so. Even in the absence of pulmonary congestion, dangerous abdominal congestion may occur. And when dangerous abdominal congestion occurs, the intra-abdominal pressure rises, the abdominal perfusion pressure declines, and finally the abdomen gives away and the patient goes into organ failure and finally into multi-organ failure. So pulmonary congestion is always relative to the left ventricle, that is, or other words, elevation of the PA pressures, whereas intra-abdominal congestion is more often related to right ventricular function, that is like elevation of CVP. So this is a factor which has to be kept in mind while deciding on fluid administration, because a lot of time a lot of patients with dry lungs apparently may also have intra-abdominal hypertension and the complications of intra-abdominal hypertension. So the systemic consequences of both intra-abdominal hypertension and abdominal compartment syndrome arising out of intra-abdominal hypertension are immense. They affect variably the neurological system, the nervous system, endocrine system, gastrointestinal function, hepatic function, integumentary or skin soft tissue function, renal function, cardiovascular function, and pulmonary function. And the main reason for all of this is a fall in the arterial flow, giving rise to ischemia. Now, this is something which has to be kept into consideration while initially treating a patient, because these are reversible up to a certain point of time. But once that time elapses, then it is very difficult, or rather impossible, so to say, to change the outcome. Now, early recognition of abdominal compartment syndrome in patients with acute pancreatitis is extremely useful, as has been found by the World Federation of the Gastroenterological Federation. So they recommend measuring only the intra-abdominal pressure in cases of patients who present with severe acute pancreatitis with Apache score 2 score of more than 7, MODS of greater than 2, or Glasgow-Imrie score of more than 3. The same also recommends continuous monitoring of intra-abdominal pressure in all cases where the patient suffers from severe acute pancreatitis and has an IAP of more than 18 millimeter of mercury on the first measurement. So that is why we can say that the first measurement or the baseline value of IAP is extremely important in these patients. The management of intra-abdominal hypertension and abdominal compartment syndrome in acute pancreatitis mainly serves to fulfill the 5 purposes that you can see enlisted on the left. 1, the therapies to improve the abdominal wall compliance. 2, therapies to evacuate the intraluminal contents or intra-abdominal contents. 3, therapies to restore fluid balance. 4, therapies to maintain abdominal perfusion pressure of more than 60 millimeter of mercury. And 5, abdominal decompression. So the factors which are responsible for abdominal wall compliance include sedation, analgesia, neuromuscular blockade, considering supine position less than 20 degrees, avoiding prone position, removing constrictive dressings and abdominal eschars, etc. So when these are attempted and these are fulfilled, then we take adequate measures to improve the abdominal wall compliance. And likewise, for each of these conditions, there are specific steps which must be initiated to ensure that the conservative approach to manage intra-abdominal hypertension and prevent ACS from developing has been taken. Now, the next point comes of IAP monitoring. And in this case, I must say that intravesicular IAP measurement is still the convenient and is considered the gold standard method for measuring IAP. This IAP can be measured intermittently or continuously. In continuous IAP monitoring, we need to have an extra stopcock, which should be turned accordingly so that the urine of the patient can drain independently of the recording the changes of abdominal perfusion pressure. And the IAP increases at the end of end inspiration and decreases at the end of expiration. So this difference is the delta IAP and is calculated as a difference of the two. In mechanically ventilated patients, the delta IAP is related to the compliance of the abdominal wall, about which I have mentioned just a short while ago, and how this compliance of the abdominal wall can be ensured. Another surrogate parameter for compliance of the abdominal wall is abdominal pressure variation. Just like you have pulse pressure variation, etc., you have abdominal pressure variation, which is calculated as the delta IAP that I have mentioned, which is the difference between end inspiration and end expiration of intra-abdominal pressure. So that is divided by the mean. In mechanically ventilated patients, this mean change of intra-abdominal pressure will better reflect the true impact of sustained intra-abdominal hypertension as compared to the others. So, based on the presence or absence of the devices which are required for the purpose of doing this continuous intra-abdominal pressure monitoring, the protocols for measurement of intra-abdominal pressure should be developed for each ICU based on the locally available tools and equipments. So what is done here may not be appropriate for in other parts of the country because of lack of logistics or some other issue. So all these things are important and should be kept in mind. Now, it is also important to know what steps should we follow to produce a reproducible, so to say, intra-abdominal pressure management. So this is measured at end expiration, performed in supine position, zeroed in at the iliac crest in the mid-axillary line. Here you can see. And the priming volume should be less than 25 ml of saline, or else the sensor would think that this is also a volume which is coming from inside, and so there will be a falsely negative reading. Measure 30 to 60 seconds after installation to allow for bladder detrusor muscles. If the bladder detrusor muscle is contracting, it is good. If it is not contracting, then also it can lead to 4 or 5 differentials, and it is good to avoid them. And measure in the absence of active abdominal muscle contraction. So that's what I wanted to say when I meant that what are the muscle contractions and why we need to install lesser amount of priming volume. And because the intra-abdominal muscles can contract, and this may raise the intra-abdominal pressure, which can be attributed as to the disease where it is actually not so. So another important point, or it is good to remember, is that diagnosing abdominal compartment syndrome is difficult in sepsis. Technically, the diagnosis of compartment syndrome is based on the basis of higher pressures, which should be at least 20 millimeter, and a new organ failure. However, these two entities exist as a continuum rather than being fundamentally distinct. However, patients in septic shock already have organ failure. How much of the organ failure it is very difficult is because of elevation of intra-abdominal pressure, and how much of it is because of sepsis, it is often difficult to ascertain. And this is the reason why diagnosing ACS is difficult in presence of sepsis, be it other patient or be it a patient of acute necrotic pancreatitis. Also, we have to remember that in patients with COPD, continuous IAP monitoring can assess the patient-ventilator interactions and dysynchrony, as well as the work of breathing. So the most important subject or the point of concern is how to drain the collections in acute necrotizing pancreatitis. As a rule, we don't drain routinely, but as I said in the beginning of my talk, when there is pancreatic pressure, which has been rising successively over hours or 1 to 2 days, despite giving the conservative medicines, that also is an indicator to drain the collections. The Pancreas Network of New Zealand created a well-organized classification system, which they termed as VRP classification. And This VRP classification occurs for V as for visualization, whether it is radiologic, endoscopic, or open, route of administration, that is percutaneous, retroperitoneal, transperitoneal, etc., and the purpose, whether it is purely drainage or it is drainage plus lavage or it is drainage plus lavage and debridement. So accordingly, we have the nomenclatures for a lot of these procedures which aim to collect the acute necrotic material before the wall of necrosis is formed. So these are percutaneous, retroperitoneal or transperitoneal drainage, endoscopic transmural or transpapillary drainage, minimally invasive retroperitoneal necrosectomy, etc. But what is important is to realize that the most widely recognized step in the management is the step-up approach. Step-up approach is a strategy where interventions or treatments are implemented in a phased manner, starting with the least invasive and progressing to the more aggressive measures only if it is deemed necessary or important. It is seen that with step-up approach, there are not only reduction in complications, but there is also a lowering of the mortality, improved outcomes, and reduced healthcare costs. So initial drainage as per the step-up approach can be either a percutaneous drainage, PCD, or it can be an endoscopic drainage, where PCD is either not feasible nor available. The second step is minimally invasive necrosectomy, like the VARD. VARD is video-assisted retroperitoneal debridement or laparoscopic necrosectomy. So when the former two don't serve the purpose, we go for minimally invasive necrosectomy. And finally, of course, we have open necrosectomy when minimally invasive procedures are also not successful individual approaches, or if there are complications like open surgical necrosectomy, etc., it becomes difficult. So the management of acute pancreatitis and its associated complications always require a multidisciplinary approach involving gastroenterologists, involving intervention radiologists, and involving as well the surgeons. This trial, the PANTHER trial, which compared the step-up approach with primary open necrosectomy and brought out into light the importance of step-up approach. And it showed that 35% of the patients who did not require any further intervention and they were managed with the step-up approach, and also they had significantly lower incidence of new onset organ failure and diabetes. Another study, which is the tension trial, compared endoscopic versus surgical step-up approach for infective acute pancreatitis. The tension trial, the initial period of 6-year follow-up was on endoscopic step-up approach versus the surgical step-up approach. And this study was followed by extension study, which had a long-term follow-up results of 83 surviving patients. And they did 42:41 ratio. And they found that there was no difference in mortality or major complications. Overall, fewer pancreaticocutaneous cells and fewer re-interventions after the initial 6 months follow-up. So the endoscopic approach lowered the risk of developing pancreatic cutaneous fistulas. This was important and resulted in a fewer re-interventions during long-term follow-up. So although there was no difference in mortality or major complications, but the risk of developing fistulas were less when endoscopic approach was used. So these are the possible interventions which are possible in necrotizing pancreatitis. One is endoscopic transluminal drainage. So that is again the first approach. It falls within the first list. Endoscopic necrosectomy. So that is also the first list. And percutaneous catheter drainage, open surgery, and minimally invasive surgery. They have certain contraindications and they also have their own complications, but yet they are very useful at times. So in the summary of management, if a patient comes with acute necrotizing pancreatitis and the diagnosis is confirmed, we first have to go for conservative management. And after conservative management, the patient can have complete resolution of the pancreatitis. If during conservative management, patient develops any abdominal catastrophe in the form of bleeding, perforation, etc., patient has to undergo urgent surgery. If during conservative management, patient's infective pancreatic necrosis, they go, then we have to adopt a step-up approach. If the step-up approach fails, we go for open necrosectomy. If there is failure with ongoing sepsis and clinical deterioration, then also a step-up approach can be adopted. So the summary of the step-up approach is that once the conservative treatment is failed, the step-up approach is initiated with percutaneous drainage. If there is failure, even after 72 hours with percutaneous drainage, either single or multiple, they can move on to the single or multiple VARDs, that is video-assisted retroperitoneal debridement, because retroperitoneum is the area or the window through which one can very easily reach and also make correct assessments. And finally, of course, is open necrosectomy. So this is always a last option. And if the patient undergoes open necrosectomy, it should be ensured that the wall of necrosis has already been formed. So my key takeaways at the end of this would be intra-abdominal hypertension is absent in mild acute pancreatitis, but can be present in moderate and severe acute pancreatitis. Intra-abdominal hypertension can determine an ominous clinical outcome, and its surveillance should be considered as a routine intervention. Efforts should be made to initiate early treatment in order to prevent its progression to ACS. And most patients with intra-abdominal hypertension and even abdominal compartment syndrome are able to respond to non-operative strategies. Yet it is refractory abdominal compartment syndrome should prompt surgical decompression due to elevated mortality, but this decision may be difficult and should be held by a multidisciplinary team. Thank you so much.